Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. Hello, everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Doug Maynard, your host for the next hour or so, and Spark Live is where we gather each Wednesday to curate and convene and showcase excellence and innovation from across the child and youth healthcare community with our goal to spark conversation, ideas, and action. And since we are live for these sessions, I do want to remind everyone that you do have the opportunity to ask questions. You'll do that by typing your questions into the question box. And also, I want to remind you to type those questions in as you think of them. We may take questions at any time throughout the session, so just if you have a question, just type it in as you think of it. Even if you are wondering if we're going to potentially answer it during part of the presentation, feel free to just ask it anyway. And also feel free to share your thoughts on Twitter, and be sure to tag us at Child Health Can. And today we're going to be talking about, speaking of innovation and excellence from across the country, we're talking about the first North American hip surveillance program for children with cerebral palsy. So a North American first by our own folks within our Children's Healthcare Canada community. But before we do that, I just wanted to make a special announcement. You may have seen today, you may have seen over the last few weeks, it's not a very well kept secret. There's been a lot of information about this going out around events and stuff, but we finally have been given permission to announce today that we've launched a new knowledge mobilization network in partnership with Dr. Christine Chambers at Dalhousie University. It's called SKIP, Solutions for Kids in Pain, and it's part of the Government of Canada's Networks of Centres of Excellence program. And the new knowledge mobilization networks of Centres of Excellence are co-directed by a scientific lead, which is Dr. Christine Chambers, and a knowledge user lead, which is myself, Doug Maynard at Children's Healthcare Canada. And we're actually launching, I'm heading to Halifax this afternoon to do the official launch in Halifax. So if you want more information about that, you can go to kidsinpain.ca, and there's not much information there yet, as we are literally just starting. And there are a number of events. There's going to be launch events in Halifax, which is tomorrow, one in Toronto on April 24th. We're doing an event here in Ottawa on Parliament Hill on April 30th, and there will be another one to be determined out in Edmonton in May. And we don't have the full details on that one yet. Those 4 locations are the hubs that will be part of the initial hubs that will be part of the new network. So again, lots more information to come, but do sign up. Go to the kidsinpain.ca website and feel free to sign up for the newsletter, and that way you'll you'll be sure to get the latest information as it becomes available. So back to today's session. As I said, we're talking about the first North American hip surveillance program for children with cerebral palsy. I remember Dr. Maureen O'Donnell, when I first started here 10 years ago, or more than 10 years ago now, talking about this new program that they were started and was going to be groundbreaking and all sorts of great things. And I almost forgot about it in the middle for a while there, about 5 years ago. And then all of a sudden I started hearing about it again. And so now here we are, almost 10 years later, with what they've learned over the past 5 years, now that they've got this program up and running. So it's going to be a great opportunity to hear what they've been up to. So we've got with us today Stacey Miller, who's the hip surveillance coordinator, and she's also a physiotherapist at BC Children's Hospital and also with Child Health BC, located in Vancouver. She's also a clinical assistant professor in the Department of Physical Therapy at the University of British Columbia. And joining Stacey is Dr. Kishore Malpuri, who's a pediatric orthopedic surgeon at BC Children's Hospital, also, of course, in Vancouver. He's with the Department of Orthopedics, and he's an associate professor at the University of British Columbia in the Department of Orthopedics. So without any further ado, it's my pleasure to hand the virtual podium over to Dr. Malpuri and Stacey Miller. Over to you guys.
Great. So Again, I'm Kishore Murpuri here. Stacey will actually do most of the talking, and I'll have brief introductory remarks, and then I'll be here to take any questions at the end of the presentation. So this whole journey of hip surveillance started when I arrived here to do my fellowship and then to start my practice here in 2003. We were seeing a large number of children with cerebral palsy with dislocated hips. And, I worked in Australia before coming here, where there was an organized surveillance program. And the thought then was, what does it take to start a program here so we're not doing a lot of salvage surgery? And fast forward that another 12 years, and with a lot of help from a lot of different people. But one person that I'd like to recognize is Maureen O'Donnell and her leadership with Charlotte, BC, that really made this possible. And now there are a lot of other provinces in our country and a lot of other regions in North America that are really looking at developing their own programs. So really the impact of this program goes beyond BC. So with that introduction, I'll hand over to Stacey, who's actually been involved right from its inception to really all the way till our journey till now. So there's no more authentic person than to take us through this than Stacey.
Thanks. It's interesting, Doug mentioning that he heard about this 10 years ago, and Kishore saying, it's been 12 years since he's been here. I was thinking about this title that I put on here the past 5 years, and really it should probably be the last 10 years. It's taken us that long. So just to give you an outline of where we're going today, I'm going to give you a little bit of background just on hip displacement and why hip surveillance is important and why we've kind of come on this journey. We'll describe the work that we've done in developing and implementing surveillance here in British Columbia and some of our successes and challenges along the way in developing a population-based surveillance. And recognizing that not everyone's going to have the capacity to do population-based surveillance in the time that it takes, we do want to identify some of the things that you can be doing now in the absence of doing system-wide surveillance. So before we get started, I'm curious to know people's thoughts on surveillance before hearing this presentation. So we're going to do a little poll of the audience here, and so if you can give us your opinion here. So hip surveillance together with orthopedic intervention should be used to prevent hip dislocations in children with cerebral palsy. So you can either vote true, false, or if you don't feel like you have the answer to that, just feel free to put undecided.
All right, so for those of you who have not done a poll with us, this is your opportunity to just provide your input by going up and clicking that answer choice on the screen, as Stacey has mentioned. Just looking to see if your thoughts on whether you think hip surveillance should be used to prevent hip dislocations in children with cerebral palsy, true, false, or undecided. Give everyone just a couple more seconds to come in. I saw somebody put an answer into the question box. Oh, you don't have to type it in there. Just click on the screen and make your selection, and it'll be added to the bunch. All right, so we'll just close that off. And it looks as though 83% are on your side and say that it should be used to prevent hip dislocations in children with cerebral palsy. Only 6% saying false and 11% undecided.
Okay, so we'll see if we can change those false and undecided votes in the next half an hour or so. And later on in the presentation, you'll see what orthopedic surgeons across North America felt about that question. So just the background, so hip displacement is, we know, common in children with cerebral palsy. So these x-rays here, the one on the left, you can see shows normal hip development. So nice round femoral head, nice round ball on the femur covered by a socket that's well developed. And the radiograph on the right-hand side of your screen there shows a hip that's displaced. So the hip on the right is about 50% displaced, and the one on the right is fully dislocated. Or sorry, the one on your right, the left hip, is fully dislocated. And we measure what's called migration percentage. So measure how much of the femoral head is outside of the coverage of the acetabulum. So for this hip here is about 50%. And when we talk about kind of hips at risk, we say anything that's over 30% uncovered is something that needs to be more closely monitored. So this hip's about 50%, and the other one, which I haven't drawn the lines for, is fully dislocated. So the migration percentage would be 100%. And we know there's this natural history. So kids with cerebral palsy are born with a normal hip joint, but over time that hip can move laterally and posterior most typically. And then you can start to see as you go through this series of x-rays that there's changes to the acetabulum, so it kind of loses its cup shape. And then to the point where the hip's fully dislocated, and it's really hard to tell where the acetabulum ends. Left dislocated, the head can become deformed, so you can actually end up with this triangular shaped head. And at this point, our management options are fairly limited. So I said it's a common problem. We know from multiple population studies that 1 in 3 kids with cerebral palsy will have hip displacement. But more importantly, we know their level of risk is based on their ability to move themselves. So many of us will be familiar with the gross motor function classification system. So it's a 5-level classification system where kids at level 1 are able to walk and run, but have problems with balance and coordination, versus kids at level 5 need help for all of their mobility. And there's multiple population studies that show that your risk for displacement is directly related to that GMFCS level. So we know kids at level 5 are the highest risk. And again, this is data out of one study out of Australia, but there's multiple studies that have kind of shown this direct relationship. So we know it's a common problem, but how important is it? Well, we know, again, as you go through this progression towards fully dislocated, that children are more likely to have pain, decreased quality of life, and loss of mobility. If you look at the literature related to pain and hip displacement, it's a little bit all over the map. And a lot of that's related to looking at the population that's being studied. But there's been lots of good studies that have been done in the last few years. And a study by Ramstad showed that migration percentage greater than 50% was associated with increasing hip pain. A study out of Australia looking at youth at skeletal maturity found that as the hip morphology was worse, so higher migration percentage, more dysplasia, they were more likely to have pain. And then a study out of Toronto showed that hip displacement was one of the most common causes of pain in children with CP. These x-rays are both from kids that are known to us here at Children's in BC. So kids at level 4 and 5 use a wheelchair for their mobility. And so these kids have lost their ability to sit comfortably. And so we've really taken away their ability to participate in their daily activities. And this is a young man that came to Dr. Malpuri's clinic in a wheelchair. He was previously ambulatory, but lost the ability to walk. And you can see here, his left hip is fully dislocated, and at the age of 22 needed to have a hip replacement. So not surprising then, based on this kind of pain and loss of mobility, the impact that it can have on a child's quality of life. And there's now literature showing that as hip displacement increases, that quality of life scores decrease. So not just a common problem, but an important problem. And so then we look at, so what do we do to treat it? And it really depends on when the displacement is found, how many secondary bony changes there are, whether the child has pain, the age, and of course, always important is the wishes of the child and the family. We knew going into starting surveillance that the one question that we would get most often from families and from therapists would be, if we're finding displacement early, is there anything we can do to prevent it from getting worse or to slow it down? And so we did a systematic review that was published in 2017, looking at all interventions other than orthopedic surgery. So that included Botox. I think there was 4 articles on Botox and 2 with Botox and bracing. There was 1 article on complementary and alternative medicines, 1 on intrathecal baclofen, 1 on obturator nerve block, 8 on positioning, and 7 on selective dorsal rhizotomy. And overall, the level of evidence was very low. The quality of the studies was low. And so based on our results, there was really insufficient evidence to say any of those had any impact on displacement. That being said, there was nothing to say that they weren't effective either. The level of evidence just wasn't there. So that doesn't mean that we don't kind of use any of these. I would say particularly positioning, we do recommend kids that are sitting in wheelchairs have a pummel to keep their hips in some abduction. If it works for them, we'll recommend that they stand in their standing frame in some abduction as well. But ultimately, when we're educating families, we can say to them that we don't know that any of these interventions are going to be helpful. So looking surgically then, traditionally surgical interventions have been categorized into preventive surgeries, reconstructive surgeries, or salvage surgeries. And so preventive being adductor releases. And I think it's a bit of a probably misnomer now. We know that there's a good study that was published out of Australia by Ben Shore, who looked at if you had a adductor release. So the starting of this graph is all the kids had an adductor release, and success was considered that they didn't need to go on to have any further surgery or had a migration percentage under 50%. And so it's effective in most kids with GMFCS level 2. So we know those kids are at low risk already. That top blue line shows they tended to be to do well, versus kids at level 5, this green line at the bottom. Most of those kids were not successful. They needed to go on to have other surgical intervention or had a higher migration percentage. So again, not saying that we don't use adductor surgery, but often we'll educate families that there could be more surgery down the road. So most commonly used is reconstructive surgery, where the hip joint, the hip is put back into joint, and potentially the acetabulum is reconstructed. And you can see that here. So the femur is now pointed back into the socket, and this is called an acetab. The acetabulum has been reshaped here with a little piece of bone. And so we have these reconstructive surgeries, but do they help? And so there is a study that shows that preoperatively kids had lower scores on their health-related quality of life, but postoperatively the surgery was successful and quality of life improved postoperatively. What we're really trying to avoid is the need for salvage surgery. So you saw earlier that triangular shaped femoral head. In such cases, the surgeons often can't put that back into the joint, and so they're forced to do what Dr. Malpuri often calls a deconstructive surgery, where the femoral head's removed. And the outcomes of this type of surgery are less than optimal, and often the children continue to have pain. So really the moral here is that early detection lets us have greater treatment options. And our ultimate goal is to make sure that kids have the opportunity to have surgical intervention with really the goal that kids at skeletal maturity end up with a hip that's mobile, pain-free, and in joint. The problem is that, as Kishore said, when he started here, 1/3 of the surgeries that he was doing in a period over 18 months were these salvage type surgeries. And I think it's fair to say that he was becoming increasingly frustrated with that, having come from, as he said, Australia, where they had a system of doing surveillance. And so we compared the types of surgeries that we were doing here at Children's with the types that they were doing in Melbourne. And you can see here the fairly dramatic difference in the types of surgeries, where they were doing many more preventive and reconstructive surgeries. We were doing the opposite of doing lots of reconstructive and a huge number of salvage surgeries. And so that really made us turn to the evidence for hip surveillance. And so when we talk about surveillance, it's really a method of identifying and monitoring early indicators of hip displacement through systematically screening, with the aim to get kids to a pediatric orthopedic surgeon at an appropriate time when all management options are available to them. There's two components typically, clinical exam and radiograph. And frequency in programs is based on the child's risk. So there's lots of evidence now supporting the use of surveillance in children with CP. I've just put two articles here. Sweden has certainly been a leader in publishing data about surveillance. They published a few years ago 20-year results showing that they've essentially eliminated the need for salvage surgeries, but even they report a very low rate of dislocations in the whole country. As well, Australia, another leader in this area. This publication is out of Queensland, where they have a program, and this is 5-year data, but they have also got 10-year data, which I think they're in the process of publishing. And again, showing that no children dislocated without being seen by an orthopedic surgeon. So in British Columbia, that really led us to starting to try to raise awareness for the need of surveillance and to create a case for getting hip surveillance started in our province. And so there was lots of advocacy in the first kind of couple of years by Dr. Mulpuri as well as myself, where we really started talking to anybody that would listen with these kind of key messages that late surgery, particularly salvage surgery, was associated with increased morbidity, higher costs, greater risk, as well as the fact that there's this growing body of evidence to show that hip surveillance really is the kind of standard of care at this time. And the failure to implement surveillance could contribute to decreased mobility and quality of life, most importantly for the children that we deal with. So we were fortunate in 2011 to be paired with Child Health BC, as Kishore said, led by Dr. Maureen O'Donnell. Through Child Health BC, we were able to bring together a group of about 50 people from across the province, where everyone was represented regionally as well as by disciplines. We did have a parent there as well. And we brought everybody together to really just to say, do we want to do hip surveillance in our province? And if so, what would that look like? And so these were the meeting objectives. We looked at what was being done internationally, primarily in Sweden and Australia. They had published guidelines, so we looked at those and looked at how would that kind of fit within our province. And I have to say that when we had that meeting, I thought it was going to go very differently than what it did. I anticipated we'd get much further, but we actually spent that full day and a half really discussing what those guidelines should look like in our province, and didn't get towards talking about how we would implement those as we had originally suspected we would. But we spent 2 days and came up with this guidelines for how we thought surveillance should work in our province. And again, based on kids' GMFCS levels, is how frequently they would get surveillance. And so we moved forward with these guidelines, but in 2017, again, led by Maureen O'Donnell, the American Academy of Cerebral Palsy and Developmental Medicine brought together international experts. So we were involved with this, as well as folks from Toronto, as well as the United States, Scotland, and Australia, and looking at how everybody that we could find internationally was doing surveillance, and came to consensus on what we thought surveillance guidelines should look like. And so in 2018, we updated our guidelines to reflect the international consensus. So if you compare what we do in British Columbia to the ACPM guidelines, they're very similar. There's just one change. We changed the age for the clinical exam and x-ray for kids at GMFCS level 1 and level 2 from age 6 to age 5. And that's just to reflect how our services are offered in British Columbia when children enter school. Our quick guide, as I said, it really matches the ACPM guidelines. It's just a bit simpler with respect to the fact that we don't put details about when to modify the surveillance or when to discharge, because we have the capacity to make those decisions ourselves. BC's clinical exam, so again, consistent with the ACPM guidelines. So we look at the child's GMFCS level. We obviously need to know that to know how frequently they should be getting surveillance. For kids that have a unilateral CP, so a hemiplegia, we look at their gait pattern, because as you can see on these guidelines, there's a separate row at the bottom there for kids that have that specific gait pattern. We know that they are at a higher risk of having displacement later in their adolescent years. We also look at hip abduction and ask questions about whether the child has any pain and look for pain on clinical exam. So you'll notice this clinical exam is really quite small, and that was done purposely. We know there's very little evidence to show that any of the clinical exam findings are reflective of what's happening with that actual migration percentage. So what's most important is really having that x-ray done, and a single AP pelvis radiograph is recommended with standardized positioning. And our colleagues in Melbourne have kindly shared with us their positioning graphics here. And again, so the most important thing is off of those x-rays is that we measure the migration percentage. And it's been shown to be a valid and reliable measure. And so based on the clinical exam and x-ray findings, we recommend a referral to orthopedics when the migration percentage is greater than 30%. We do recommend a referral if abduction, so how far apart the hips can go if you try to spread them apart, is less than 30 degrees. And again, there's no evidence to say that a child's at higher risk based on that, but the international group still felt that those children should be referred. And then, of course, if there's pain on clinical exam or on parent report. And really, if there's any kind of clinical concern related to the hip, we're happy to ensure those kids are referred to orthopedics. So my second question for the audience here is, in your practice or your institution, wherever you're working, if you know, do you follow regular hip surveillance guidelines or a protocol? And so that might be your own, it might be the ACPM guidelines, it might be BC's guidelines, Australia's, Sweden's. Just curious if in your practice, do you follow guidelines?
All right, so once again, your chance to provide your input by clicking, selecting your choice on the screen and just clicking beside yes, no, or I don't know as to whether you follow regular hip surveillance protocol. And we did have a question that came in while you were presenting. So while we're waiting here, I think this is a fairly simple one.
Sure.
Someone asked, who does the clinical exam? Is it a physiotherapist? Is it a physician? Who's responsible for that clinical exam?
Yeah, it's a good question. And so in British Columbia, we have our physiotherapists throughout the province that we ask to do that clinical exam. And I'll explain kind of the next section, kind of how we implement surveillance in BC. Okay. So that's all coming.
All right, sounds good. All right, so the results are 58% said yes, they do follow regular hip surveillance protocol, 31% said no, and 12% said they don't know.
Okay, so that's pretty good. So that's encouraging, actually. And I was curious to ask that question because this paper was published a few years ago. They did a survey of POSNA membership. So that's the Pediatric Orthopedic Surgeons of North America. And so we talked about earlier, I think, I didn't write the number down, but 93% of orthopedic surgeons felt that hip dislocations should be prevented by surveillance. I can't remember what our first poll said. It was 70 something, I think. But of those surgeons that felt that surveillance should be used, only 18% were actually following regular surveillance protocols. So surprisingly low for considering how much support there was for actually doing surveillance. And I think also surprising to me from those results was that a very high percentage, like 98% or something like that, said if there was national guidelines that they would follow those guidelines. But I think the moral here and a lesson learned from us, and you'll see as we at the end of the presentation when we start talking about outcomes, is that really even just adopting guidelines and following those is a great place to start, and you can actually do a lot of change just by following those guidelines. And the other part I would say is just really about education. So whether that's, depending on your role, whether that's educating families or educating your colleagues, educating physiotherapists that are seeing these kids, educating physicians, any chance you have to educate about the need for hip surveillance and that hip displacements happens and is common, I would encourage you to take those opportunities. So going back to our meeting, we talked about in 2011, I had thought we would end up talking about implementation, but that didn't get spoke about at all in that first meeting. And so we had a second meeting about 8 months or so later where we talked about implementation. And I think this is where the challenge starts, really. I think now there's a lot of opportunities for people to adopt guidelines that are readily available. And so I think now that's the easy part, is deciding which guidelines you want to follow or adapting ones to fit your practice area. But looking at implementation is where it becomes much more challenging. And it certainly different no matter what system of care you're in. And so what works in British Columbia, I will say, was not necessarily what's going to work in your system. But I will say that when we looked and brought this group together, again, to look at implementation in BC, we had these kind of key questions. And I think these hold true to no matter where you are. And if you're looking at implementing surveillance, that you need to consider these questions. And so those are, who's going to identify the child? So how do we find all the kids in your system that have cerebral palsy and require surveillance and across GMFCS levels? And who's going to complete that clinical exam? So that question of who's doing that clinical exam. How are you going to keep track of that? So who's going to coordinate when surveillance is due, when those clinical exams and x-rays are due to be done? And how do you manage all of that data? So you can think of in a system how many kids you're potentially following, and your amount of data and trying to flag when things are due can become messy very quickly. Who's going to request the x-ray? So is that the child's family physician? Is it an orthopedic surgeon? Is it their pediatrician? So whose responsibility is that? And then who's going to measure the migration percentage? So typically in a lot of centers, it's not something that's regularly measured by the radiologist. So are you going to teach the radiologist, or how is that? Who's going to do that measurement? And we know from the evidence that having the same person do it is much more reliable, or at least a small group of people that have looked at their own reliability within each other. So when people contact me, and a number of people from across Canada have been in touch, which is great, these are usually the questions that I start asking people is, what in your situation is going to work for all of these? And so when we had the group together in BC, we broke people into different regions. Our province is vast geographically, and so we broke people down into their regions and said, what's going to work in your region? And I think a little bit surprisingly, everybody came back. We kind of gave them different models. Everybody came back and said really the same model, and so that made it easier for us. This is our model, and I'm not going to go into it, but what was decided, and I'll point out to you here, is that anybody can identify the child. So that's that kind of top corner. So anybody can identify the child as needing surveillance. We asked the community physiotherapist to do the clinical exam and to kind of explain the program to the therapist. And I think importantly, the physiotherapists that were in the room identified themselves as being the most appropriate person to be doing that role. They kind of said, you know what, we're seeing these kids already. We know the families. We have the skills to do the clinical exam. And so they identified themselves, which was great. The group just said we did need a surveillance coordinator. And so that's kind of this role down here. Anything in the purple is the database. So we did say we needed a way of managing all of this data. And by no means do these kind of sizes of panels represent the scope of the role, but you'll see here in the middle is the parent, and certainly the most important role there. And over at the corner here is when the child's referred to the orthopedic surgeon. So this is, I think, a little bit friendlier way of looking at it. So we have child development centers and schools throughout the province. And so we ask those physiotherapists to identify kids with cerebral palsy. As I said, talk to the families about them, and we've given them education materials to do that with families. They then send us that information, and as the coordinator, I look at that and decide whether a child needs to have an x-ray. If they do, we mail them the x-ray requisition. They can get the x-ray done in their home community, so there's no travel for those families, which is important given our geography. As long as the x-ray is done at a local hospital or healthcare center that's hooked in with our provincial health authorities, then we can look at those images. So we look at the x-rays and measure the migration percentages for all of those x-rays. And as I said, so we send the x-ray requisitions, so all of those are under Dr. Walpurgi's direction. So as I said, that was all of that kind of planning was done in 2012. Fast forward another 2 years where there was kind of the business case and kind of the development of that business side of things. And in 2014, we were very fortunate that Child Health BC continued to be supportive of the program and launched what's now known as the Child Health BC Hip Surveillance Program for children with cerebral palsy. And our initial goals in setting up the program were really to establish a province-wide consistent standard of care for hip surveillance across the province, and to ensure that children, no matter where they lived in our province, could receive appropriate screening. And we really wanted to support community therapists and families so that all of this could be done locally. And ultimately, again, to ensure that kids who need to see an orthopedic surgeon are doing so at the appropriate time. So our first kind of phase, and I would say it took us about a year to get all of this work in place, was really looking at a communication plan. So who are all the people that we need to tell this, new program is starting. You saw that map of where everybody works for the child development services. And so we had to kind of map out who all of those service providers are. And as part of that kind of initial learning, we did a knowledge and needs survey, and I'll explain some of the findings of that. But we did a survey of therapists across the province to figure out what their kind of learning needs were, given that they were such a big part of implementing the program. And subsequent to that, had to develop all the knowledge translation materials that would support them and families. I think an important part that we did early on was we assembled a provincial advisory committee. So we had in that kind of first 2 meetings about 60 people, but we've pared that down to about 30 that continues to meet twice annually to give us feedback on how we're doing with surveillance. And we get to ask them all kinds of questions about how we should be moving forward with implementing. It's taken us, we started this in that phase 1 of building a data management system, and say we're almost complete. It's taken us a very long time, but it's kind of integral to making the surveillance program work smoothly. And then importantly, given we're the first program in North America, we wanted to make sure that we were doing a very good job with evaluating. So we have a detailed evaluation plan as well. So as I said, we did a knowledge and needs survey. So that first survey that we did in 2015, we looked to therapists in the province, and we had 102 responses from physios, OTs. And you can see here working in across the province, so metro to remote areas, and an interesting look at the demographics of therapists in our province. So a vast majority are very experienced. And so one of the first things we wanted to know was, do they think, are they supportive of surveillance? And we were very fortunate to find that more than 95% of therapists in our province were supportive of what we were doing. And so that made things easier moving forward for sure. Somewhat surprising was some of the results about kind of the knowledge and comfort with doing certain aspects of surveillance. So we asked people whether they were using GMFCS regularly, and you can see here that about 70% were, but it still meant that we had to do some knowledge translation to make sure that, given that surveillance is based on GMFCS levels, that we really need that to be 100%. And then, do they routinely do a clinical exam for identifying hip displacement? And that was kind of all over the map. But a large percentage weren't. So it means that we really needed to change their practice. And so work to do to get that to happen. And then we asked just questions about whether they were competent in knowing when children should get a clinical exam or an x-ray, and even just measuring hip abduction when we look at the components of the clinical exam. And again, it's kind of a little bit all over the map. So definitely work to do to educate the therapists across the province. We asked them how they wanted to get information, and there was lots of different ways. And so we really tried to make sure that we offered multiple ways of getting information. And so that led us to creating a number of education materials. So there's an online learning module, which is freely available. So you can go to our website, and there's about a 45-minute learning module on hip surveillance. We've created clinician and family education booklets. We really developed the website to make sure that all of these resources are readily available. There's the clinical exam. We've got written instructions as well as being kind of part of the module. And then have to regularly try to keep this kind of knowledge going by doing webinars and in-person education, as well as we send out a newsletter regularly. So these are just examples of the knowledge translation materials that are available, and again, freely available, and we're happy to share these with people. Just be in contact with us, and we can chat about if you're wanting to use any of these. We did, I would say one of the questions that I get very frequently is around radiology and positioning, and so whenever we send an X-ray requisition, we send out this information sheet. And then importantly for families, and I would say a large portion of our knowledge translation to families is through community therapists, but we've also made announcements through our CP Association, and a big ask has been to start using social media more, and so we're moving into that. And so I would say if you're familiar with knowledge translation literature, I think this is probably fairly standard, but we've certainly learned that we need to use multiple methods, continuously educate, and really have customized strategies for all of our different stakeholders. So this leads us to kind of our rollout. So we started in 2015 just enrolling kids here at Children's, added 2 test sites in February of 2016, and did a full provincial rollout in August of 2016. This just shows our paperwork that we ask people to fill in and fax to us. So to date, we've enrolled 847 kids across the province. And if you look, we don't know how many kids in British Columbia have cerebral palsy. So if we look at what, just based on a prevalence rate in our population, we think that we've enrolled about 37% of the kids born between the year 2000 and 2017. But we know that we're unlikely to get a lot of the kids that are older. They're starting to graduate high school. They're not being followed as closely anymore. So really our target is this kind of 2010 to present. And we figure we're at about 50% based on that. If we look at by GMFCS level, so don't see a lot of kids at GMFCS level 1, probably not surprising there, given they're not always followed by therapists. But I think still our biggest want would be to increase those numbers for kids at levels 3, 4, and 5. So some work to do across all GMFCS levels. We've discharged about 28% of kids from the program, and you can see there just what proportion by GMFCS level have been discharged. And the reason for discharge, so kids at GMFCS level 1 and level 2 are discharged at a younger age, so a vast majority of the kids that have been discharged are at that level, followed by kids being skeletally mature, and we're happy with their displacement. Regionally, we do see big differences in how well we've been able to enroll kids in the program. So I think somewhat surprising to me was that we've done really well in the north at 60%, and our lowest is kind of the interior of our province. There's some complicating factors. Some kids in the interior that are close to the Alberta border do go to Alberta for their services, but we have kind of set up a system with our colleagues in Calgary and in Edmonton to still support those kids and ensure they can be part of the surveillance program. So to date, about 52% of the kids have been enrolled by their community team. The rest have been enrolled here at Children's when they've been seeing an orthopedic surgeon. And we've had about 122 different providers. The vast majority have been physiotherapists, but over the past year, we've spent more time educating pediatricians. And so we're starting to see more and more referrals coming through pediatricians, which has been great. So we asked people, we repeated our therapist survey in 2017 and asked kind of how people were feeling about the enrollment. 73% of those that responded said they had enrolled a child, and the majority were happy with how the enrollment process was going. But some of the kind of barriers that they identified were having a lack of CP diagnosis, parents not agreeing to enrollment, which was interesting. Time requirements, lack of space, and then the family physician or pediatrician not supporting the enrollment. Now, I put these as barriers, but actually the kind of vast majority of people that answered the survey said they didn't have any barriers. But we've still kind of taken these and tried to move forward with kind of working on strategies for these. We have shown, I'm not going to go through all of these results, but have shown with kind of repeating that survey that we've been able to increase knowledge in a number of different areas. And based on some of that work, we've done a survey of pediatricians as well, just to learn about their thoughts on surveillance and ask some of those same questions. And so interesting to compare the therapist versus the pediatrician. So the vast majority of pediatricians, well, the majority, maybe not vast, but we're not using GMFCS levels. Great to see, though, that they were largely supportive of doing surveillance. But it did show us that a quarter of them had not even were not familiar with our program. So certainly a targeted area for us over the last year has been to do knowledge translation to pediatricians in the province. So looking now at kind of the impact of the program. So at the time of enrollment, we asked if a child's seen a pediatric orthopedic surgeon in the past. Doesn't mean they're still being followed, but 65% had. And to date, we've done 91 referrals or re-referrals to an orthopedic surgeon, and 53 of those were for migration percentage greater than 30%. And certainly there's many of those that had migration percentage 50% or higher. So kids that would not have been picked up until a much later date, potentially. I think important to show, and why I said early on that we certainly would encourage you to start following guidelines and start educating and just being aware of the program. We found that between 2008, when we kind of started on this, to the time where we launched the program, the number of salvage surgeries dropped from 35% to 15%. So really kind of showed the impact of just talking about the problem and getting it to be aware of. And then last year in 2018, there was just 4% of surgeries were salvaged. So we're seeing the kind of early results of the program. So just to kind of summarize some of our lessons learned, that certainly in our province, therapists and pediatricians have been very supportive of surveillance, and that we really need to target and customize our methods of reaching not just therapists and physicians, but families as well. That we have a vast geography, and so we've certainly realized that we need to do a targeted and staged coordinated approach to how we're implementing in our province. And that certainly there's regional differences. And so if you're looking in your system of care, that certainly looking what the challenges could be within different regions would be an important thing to consider. And that certainly recruitment takes time. So we don't know how many kids in the province have CP. So we're doing kind of our best estimate. But certainly it takes time to find everyone and kind of implement that practice change. And we've also learned that a late or lack of diagnosis of CP is a barrier to enrollment, and something that certainly is being worked on internationally as well as here in BC, is kind of changing that time at which kids are receiving their diagnosis of CP. So I'll leave this kind of as our final message, is that don't delay. There's no need to wait for system-wide surveillance. Certainly that's ideal, but start educating, use guidelines, or adapt those that are available to your needs. Use the available resources. So as I said, we have a number of resources that we're happy to let people use. Just email me. And when implementing, really, I think importantly, we've learned that you need to involve all your stakeholders and really think of those kind of key questions. So I think we're happy to take some questions.
Yeah, oh, definitely. There's definitely quite a few questions here, but just want a great presentation, and I think you know, the 10-year. I don't know if it was worth waiting 10 years for this, but certainly you've certainly demonstrated some amazing outcomes with this program. Given like, you know, even though it took 10 years, I think a fantastic work. And did just want to point out, Dr. Maureen O'Donnell's name was mentioned a few times. She is the current chair of the board of directors of Children's Healthcare Canada. So great to have her on board and to recognize all of the work that she's contributed to over the years. Like I said, we do have a number of questions. And is this the best email address, by the way? You said to contact you for anything, hips@cw.bc.ca. Is that the best place?
Yes, yeah.
Make sure we'll leave that up there, so make sure everybody has gets that. So, and I will warn you, a few of these questions that came in do look like we do have a number of our American friends in the audience, so some of the questions might be unique to their system, so you may or may not be able to give them a full answer, or at least the answer that they might be looking for. But we'll give them to you anyway. So the first question is asking about recommendations on standing on a daily basis. And does the program, whether it's Child Health BC or any other programs in the province, are you aware of them working with the school system in order to support standing as part of their hip health?
Yeah, we don't have any kind of specific recommendations. So we have a excellent positioning and mobility team. It's run through Sunny Hill Health Center here in the province, and so they do a lot of work with community therapists across our province. And as part of that, they have developed kind of recommendations for kids, particularly at the GMFCS levels 3, 4, and 5. With respect to all different types of positioning, and that includes kind of how they should be positioned in their wheelchair, but also in standing frames. And so that education goes out. It's not necessarily through us. As I said, I certainly get a lot of questions around kind of what to do for prevention when we identify something early. And so we do encourage kids to stand if it works for them and the equipment that they have in some abduction. But yeah, we don't have kind of any specific guidelines other than kind of those recommendations.
And this next question, I think, is what prompted me to think it might be coming from an American perspective, but and this will be a difficult one to answer in Canada. The question is in follow-up to the standing question that you just answered. Do you find that insurance companies support the purchase of standers in order to support standing as part of hip health, and recognizing that in Canada, at least, those kinds of supportive devices, it varies province to province what will be covered under a provincial plan versus private insurance, et cetera, and certainly even more different in the United States, I'm sure. But in your experience in British Columbia, how does that work as far as supporting devices that might be required to support standing?
Yeah, so in our system, certainly we don't get kind of additional funding in order to kind of promote hip health. So kids have a specific amount of funding as part of being enrolled in a program called the At Home program here in BC. And so we have no influence on kind of the amount of funding or anything like that.
A very simple question here. Someone was just asking, at what age is usual skeletal maturity?
That's an interesting question, and I think in kids with cerebral palsy, it varies highly compared to what it would be in a kind of typically developing population. And I think we asked, as when we were doing the ACPDM guidelines, we asked one of our Australian colleagues who does the Queensland database, because they had that information, and it actually varied very widely from being quite young at 10 to kind of not being even skeletal mature at 20. I don't know if Keisha had anything.
I've certainly had 18, 20-year-olds who still had a wide open truncated cartilage, which in a normally developing child closes between 12 to 14. So I think that's why we call these as guidelines. So hopefully this would cover 90% of the children that we see, but still we need to use our clinical judgment on the last x-ray to make some decisions. So if you see the trilated cartilage is still open, or if you start seeing any pelvic obliquity, there are some modifiers that we can go into detail in a general guidelines that may still warrant you to continue to follow this child.
All right, thank you very much. So this question came in the next question came in when you were sort of talking about the American Academy, the ACPDM guidelines, and you aligning your surveillance program with those guidelines. You subsequently, near the end of the presentation, talked about the outcomes associated with your surveillance program and the positive outcomes that you saw. You put a lot of that information. So this question sort of preceded that, and maybe you did essentially answer it, but I'll ask it anyway. When you were talking about those guidelines from the ACPDM, they were just wondering, in clinical settings that have adopted the guidelines versus those that have not, are there differential outcomes in those patients?
Yeah, so I think that question is very difficult to answer, not unless people go back and look at them historically. And I can tell you, as Stacy pointed out, we had 3 periods where it was free for all. We had no organized way of either educating or looking at our own patient population. Then we had a period where we started consulting with our community partners, started educating people about hip surveillance and the need for hip surveillance. And the 3rd phase is actually rolling out a formal program. And we've seen a dramatic improvement from one period to another. So I think there is no doubt that an organized program like this will prevent a hip dislocation. It will not prevent the burden of managing the kids that have this problem. They will still be, in fact, if anything, you might identify more children that would need some sort of an intervention to keep those hips in. But certainly it will prevent those surgeries that we're talking about, the salvage surgeries, which are not ideal, and that's not the end of the story. And a lot of those kids keep coming back with issues.
So the next question is asking sort of similar to the line of that you were talking about the standing and hip health and that sort of thing. The next question is just asking about physical activity programs in kids with cerebral palsy and how that relates to the issue of problems or alleviation of hip problems in children. Are there physical activity programs for children with CP in British Columbia that are focused on addressing hip health?
There's not. And as I said, I don't think there's any evidence kind of one way or the other saying that anything that we do from that perspective would kind of help or hinder. So I think we really try to just encourage families to, to do kind of functionally what works best for the child and to encourage participation in whatever activities. So there's no kind of specific programs.
The next question is coming from a parent of a child. So it's always great to see our parents and families and individuals from our Canadian Family Advisory Network and others in the audience. So this parent is saying she's a parent of a child that does not have cerebral palsy, but has a rare genetic syndrome that mimics CP. She's saying she must be from BC, but because she says they had no problem, there was no barrier getting in the program, but she's curious why it's labeled with CP. There could be a broader term that was more inclusive and perhaps increase enrollment. She's just suggesting.
So I think that is an evolving debate, and I think my apologies to the pediatricians and neurologists that might not like the term that I'm going to use, and in fact, I would say, just like the way they came up with autism spectrum disorder, I think we almost need a term that is a cerebral palsy spectrum. There is, it's so difficult to add every single genetic abnormality's name to this group that would probably require exactly the same kind of follow-up. In fact, if we think about the definition and diagnosis of cerebral palsy, and that's constantly evolving, and so I think that is a very, very valid point. At this point in time, this is sort of an umbrella diagnosis we're using. And the fact that we call the surveillance, there is, we probably include more people and then rule them out later on if we need to. So my advice to anybody that's looking at this is not just for CP, but probably CP-like as well. And I totally agree with whoever's asked this question. I think we need a better term, and I know I'd get killed if I got on a podium as an orthopedic surgeon and I said cerebral palsy or cerebral palsy spectrum, and that's really what I want to say for this group of people.
All right. Well, you'll have to try that out during one of your next presentations and see how that goes, and we'll. Thanks for that answer. And this parent also put a follow-up to the question about coverage from insurance companies or provincial health programs for standing supportive devices, etc. She said not necessarily supported in BC. She was referring to the at-home program that only supports one alternate positioning device, and a standing frame is one of many devices that fall in this category. Also, they only cover up to $3,200, which isn't sufficient for most of these devices. She said there's a big review of the at-home program right now, and it would be great to get this hip surveillance team's input into that program. She says we need more cross-ministry input. So perhaps there's an opportunity to do a little bit of advocacy on behalf of children with hip issues.
Yeah, that's great. Happy if she would email me.
Sorry, go ahead.
I just said I would be happy if she would email me.
All right. And the address, of course, was hip at cw.bc.ca. Yeah.
That's right.
All right, the next, we do only have a couple more questions. We are just about out of time. We are at 12 o'clock right now, but we do just have a couple more questions that we'll try to get through here. The next question is asking, does the program notify parents or clinicians when the child is due for reassessment, or is it up to the clinician to keep, or the family to keep track of the timelines?
Yeah, so that's our responsibility as far as the surveillance coordinator and team here. We notify the child's community physiotherapist. We try to give them about 8 weeks notice of when the clinical exam is due. And then when the x-ray is due, we send the x-ray requisition to the family and give them kind of a couple of weeks and ask them to complete it in that kind of 2-week time period.
Okay, and this is the last question. We did have a question about access to the PowerPoint presentation. Just to remind people, we do record the presentation, and if we are able to get the slides from you, Stacey, we will post a PDF copy of the slides as well on the Knowledge Exchange Network, and you will, all the attendees will get an email in a few days with a link to that page. So this information will be available after the fact, or at least some of it will be. So this last question is, it's actually a number of questions, so if you need me to repeat any, I'll read them all, but if you do need to repeat any, just let me know. So the question is, what did you notice regarding the reduction in salvage surgeries for patients with GMFCS 4 and 5? Do you often do preventative surgeries in these patients? Do you often need to do a second surgery later on? And do you also see improvement in quality of life in these patients?
Yes, so I would say the salvage procedures have been replaced with, I would say most typically in our center now, with reconstructive surgeries. And Kishore can speak to that if he wants to, but certainly there is, as I said earlier in the presentation, there is now evidence showing that quality of life scores do improve if you look at them preoperatively and postoperatively. And I will say, too, that we're part of a big international multi-center study that's being led by Dr. Narayanan in Ontario, looking at outcomes of all of these different types of surgeries. And so we'll have more information about that kind of in the years to come as well. Do you have anything to add?
Yeah, no, I think I totally agree. I think we've certainly replaced salvage surgeries with more reconstructive surgeries. And the other point about, do you need to do repeat surgery? I think the younger you do need to. And that's where the big debate, part of what Dr. Narayan is leading from sick kids is proactive versus reactive. How late can you wait before you do your big complex surgery? All of those questions, to be honest with you, we don't have answers. But I do tell the parents that there's a 30% chance if I do them younger than 8 years of age that I may need to do another hip reconstruction down the road to keep the hip in. So all that surveillance does is gives you an opportunity to intervene to keep the hip in, doesn't necessarily stop or prevent the hip migration.
Yeah, and so we certainly say to families, and as part of our recommendations, is that any child that has surgery goes back on surveillance post-operatively and continue to be followed until they're skeletally mature.
All right, and with that, we are out of questions. So I'm just going to give it back to you, to the both of you, one last time. Just if there's any last key messages or closing messages you'd like to leave the audience with, anything for the vision for the future for this program, anything that we might expect to see in the next 5 or 10 years, anything you'd like to leave the audience with before we sign off.
Yeah, I just have sitting on my desk what Stacey gave me for one of the Christmas. It's from Walt Disney. It says, it's kind of fun to do the impossible. So those of you that are sitting, oh my God, in our province, in our own region, it's not going to happen. I think if you persist with it, make a business case, show the evidence and really advocate for it, I think it is possible to have your own local, regional, state, national surveillance program. So those that believe in it, go for it, go on the journey. Trust me, now that we're in this position, it is really heartening to see all these children hips in and not doing those salvage surgeries. Stacy?
Yeah, and I would say the same is that encourage people just to start and to start thinking about it. And as I have said multiple times, just continuing to educate. And where the program's going over the next 5 years, I think it's going to be exciting to look. As I said, we kind of have this detailed evaluation plan. So looking forward to kind of looking more closely at some of the data that we've produced to see what kind of where we can continue to make changes to the program and our recommendations and to make things easier for children and families across the province and across the country, hopefully as well.
With that, I think it's a great place to wrap this up. So once again, a great presentation. Thanks so much for joining us today. Some great work, even though it's taken 10 years, really some great work and really great to see it. And again, looking forward to the next 5 or 10 years to see what you guys do.
Thanks very much. And we're happy to share the slides. So I will send you a PDF of those.
Also, we're happy to share any material if anybody is planning to sort of start your journey with hip surveillance. Yeah.
All right, sounds good. And we were just talking to somebody at a hospital in Ontario yesterday who we were talking about data collection in the rehab world, and that was the first thing they talked about was hip surveillance. So hopefully you will be getting some calls from lots of people after this.
Yeah, very good. And I will say certainly we would love to hear from people if they are thinking of starting, because we would love to be able to kind of look at sharing data. So if we can be collecting some of those same kind of data points, that would be amazing.
All right, lots of opportunities for collaboration across the country. So hopefully we'll get lots of people contacting you. We can see what we can support in that regard. All right, so for the rest of you out there, we do our webinars, as most of you know, every Wednesday at 11 a.m. Eastern time, and it's great when you do get to watch live because you do get to ask those questions and put in those comments, which really enriches the discussion. But if you can't watch live, as I mentioned earlier, we do record these sessions and make them available after the fact on the Children's Healthcare Canada Knowledge Exchange Network at ken.childrenshealthcarecanada.ca. Next week, April 24th, will be our next webinar, and we'll be talking about mental health of immigrant and refugee children and youth in Canada, pathways to care and health system utilization. We'll be hearing from Dr. Natasha Saunders, who's a clinical investigator and pediatrician at the Hospital for Sick Children in Toronto. Dr. Saunders will be talking about gaps in our understanding about how and where immigrants engage with the mental health system for the first time, and also we'll be talking about the need to understand these pathways and trends over time in utilization of mental health services for optimal health service delivery across all health services for children and youth and immigrant and refugee children and youth. So a very interesting session coming up next week. So thanks again to Stacy Miller and Dr. Kishore Malpuri for joining us today. And hopefully we'll see lots of you back here for next week's presentation. Bye, everyone.